Good morning, everyone, and welcome to today's TIRO by MD session. I am Dr. Camilo Gonzalez-Velazquez, endocrinologist from Monterrey, Mexico, and it's a pleasure for me to have you all with us once again for a truly international discussion at the intersection of research and clinical practice in thyroid oncology. Today, we'll be focusing on a recently published study titled The Usefulness of a Second I-131 Treatment in Biochemical Persistent Differentiated Thyroid Cancer Patients. This will be presented by Dr. Carla Gambale. This work from the University Hospital of Pisa examines when a second radioactive iodine treatment may offer clinical benefits in patients with persistent biochemical disease after initial therapy. Dr. Gambale is an endocrinologist currently holding a postdoctoral position at the endocrine unit of the Department of Clinical and Experimental Medicine at Pisa University. She obtained her medical degree at the same university and completed her fellowship in endocrinology at the University of Naples. Dr. Gambale went to earn her PhD in clinical and translational sciences at the Pisa University, where her research focuses on the impact of radioactive iodine therapy on outcomes in biochemically persistent and metastatic thyroid cancer. Joining us as a discussant today, Dr. George Coura-Filho, assistant physician and researcher at the Department of Nuclear Medicine at the Instituto do Câncer do Estado de São Paulo at the University of São Paulo Medical School. Dr. Coura-Filho also serves as the medical coordinator at the DIMN Vila Mariana in São Paulo and is past president of the Brazilian Society of Nuclear Medicine. His clinical research continues to advance nuclear medicine practices across Brazil. And we will just continue with the presentation. I'm really honored to have you both here. I want to just invite the audience to send in any questions that you might have through the Q&A function, and we'll try to get as many of them before the end of the hour. And I'll give the mic to Dr. Gambale so we can start the presentation.
Good morning to everyone. And it's a pleasure for me to be here and to having the opportunity to show our study. We know that Radioactive treatment is the cornerstone of the treatment of a differentiated thyroid carcinoma. Indeed, after its first clinical use in 1942 and its approval by FDA in 1951, it was widely used, and during the following decades, it was used for metastatic cases and for the ablation of remnant tissue. Moreover, in the following years, several procedures related to radioactive treatment, such as stimulation of a TSH, whole body scan and dosimetry, were optimized. However, we must clarify that all these treatment and all these procedures were referred to the use of Iodine as for the treatment of a metastatic patient and for the ablation remnant tissue. Indeed, the concept of biochemical persistent disease was born only later, when in late 18th and in 19th, thyroglobulin became a sensitive and specific marker of thyroid tissue, both metastatic and remnant thyroid tissue. And only at this time, the concept of biochemical persistent disease was born. So a condition in which thyroglobulin is detectable in absence of structural disease. And at this point, we began to ask ourselves if radioactive treatment could be useful also in this setting of patients. And Several papers analyze this topic. For example, in 2001, Pacini et al. Compared two groups of patients. One group of 42 patients received a second radiodyne treatment after the initial therapy, and a group of 28 untreated patients. And at the end of follow-up, the author found that the recurrence rate varies from 25 to 36% in treated group according to the result of the first post-therapeutic according to the results of the first whole body scan. And at the same time, they found a high rate of undetectable thyroglobulin in untreated group. So they conclude that the empiric treatment could be useful in a subgroup of metastatic patients. However, considering the high rate of undetectable thyroglobulin in untreated patients, the decision if perform or not a second radiodyne treatment should be assessed on the basis of the first post-therapeutic whole body scan. And other papers analyze the same topic, and the data are controversial. For example, paper by Schlumberger demonstrate a complete remission in 20 patients with negative X-ray, but with the presence of lung metastasis at the post-therapeutic whole body scan after the empiric dose. Or a paper by Pineda showed the efficacy of empiric radiodyne treatment to reduce the thyroglobulin level. And the paper by Fautoreki demonstrate the possibility to detect structural disease after the second radiodyne treatment. However, we must clarify that all these papers analyze diagnostic whole body scan, and we cannot exclude that a number of cases with detectable thyroglobulin and negative diagnostic whole body scan were affected by structural disease already at the time of the first radiodyne treatment. If we consider only papers in which post-therapeutic whole body scan positive were excluded, the data remain controversial. Indeed, in 2018, Hirsch et al. Published a paper in which analyzed a group of 61 patients with biochemical incomplete response after the initial therapy, and a rate of structural disease after the second radiodyne treatment was about 15%. But a previous study published in 2010 reported a higher rate of recurrence. Indeed, in the group of patients receiving the empirical radiodyne treatment, the recurrence rate was 36%. However, it was very similar to the recurrence rate in control group, 32%. And in all cases of recurrence, the recurrence was in cervical lymph node. Moreover, in no one patient received the empiric radiodyne treatment was present pathological uptake at the post-treatment whole body scan. So the data about the efficacy of a second radioactive treatment are controversial. However, in clinical practice, the use of a second radioactive treatment or an empiric radioactive treatment is very, very common, as demonstrated by this survey published in 2014. And what do the guidelines say about this topic? First of all, we must remember the definition of biochemical response. And ATA guidelines, both 2015 and 2025, define biochemical response in patients treated with total thyroidectomy and with a first radioactive treatment. Biochemical response is defined in cases of negative imaging and in presence of detectable thyroglobulin above 1 nanogram per milliliter, if we considered non-stimulated or suppressed thyroglobulin, or above 10 if we consider stimulated thyroglobulin, or in cases of increasing trend of thyroglobulin antibodies. And don't forget the definition of indeterminate response, in which the cutoff, the thyroglobulin values don't reach the cutoff for the biochemical definition. However, it is not undetectable. And about the management of these patients, the ATA guidelines, both 2015 and 2025, despite the 10 years of difference, reported the same recommendation. They refer only to stimulated thyroglobulin, and empiric treatment is not indicated in indeterminate response, but may be considered in patients with higher values of thyroglobulin or in cases of increasing trend of thyroglobulin or thyroglobulin antibodies. What is the frequency of biochemical response? The rate of biochemical response in patient is different in different class of risk recurrence. Indeed, it is 11% in patient with low risk and about 20% in patients with intermediate and high risk of recurrence. Moreover, patients with a biochemical response after the initial therapy had a higher risk of structural disease during the follow-up. Indeed, the patient with the biochemical response had risk of structural recurrence of 53%, and the rate decreased to 5, 10, 20% in patients with indeterminate response. So, to recap, several patients with differentiated carcinoma experienced biochemical incomplete response or indeterminate response after the initial therapy. This implies an increased risk of structural recurrence, and the management of these patients is a matter of debate. The aims of our studies were to verify the impact of performing a second radioactive treatment in a cohort of patients with biochemical incomplete or indeterminate response after the initial therapy, and to unveil the factors able to identify the subgroup of patients who will develop the structural disease, for whom the treatment can be useful. For each patient, demographic, pathological, biochemical, and clinical data were collected until to the data lock in April 2023. And all patients were treated with total thyroidectomy, and lymph node dissection were performed only if clinically indicated. And all patients were treated with a first radiodine treatment. The follow-up strategy consists of a periodic evaluation of TSH, thyroglobulin and thyroglobulin antibodies, and neck ultrasound. Further imaging procedures were performed if one clinically indicated. The response to the treatment were defined according to the ATA guidelines and was defined as excellent response, biochemical incomplete or indeterminate response, and structural incomplete response. Among the 230 patients who performed the second radiodine treatment between January 2009 and December 2012, we excluded 10 patients who performed further neck surgeries between the first and second radiodine treatment, and 67 patients who performed the second radiodine treatment due to structural incomplete response after the initial therapy. So the study group consists of 153 patients, 86 patients with indeterminate response, and 67 patients with biochemical incomplete response. Most of patients were females, and the median age at diagnosis was 41. Classical variant of papillary thyroid carcinoma was the most frequent histology, and in more than half of cases, the tumor was multifocal, bilateral, and showed minimal extrathyroidal extension. On the other hand, vascular invasion was present in less than 20% of cases. In figure are reported the distribution of TNM stage and the ATA risk of recurrence. And most of cases, about 60% of cases, were defined as intermediate risk. The second radiodyne treatment was performed after a median time of 20 months after the first one, and in most of cases, about 47%, the reason to performing a second radiodyne treatment was the presence of detectable thyroglobulin values after RH-TSH stimulation. The response to the treatment was defined at the following at the first clinical evaluation after a median time of 8 months after the treatment, and 11.8% of cases showed an excellent response, 17% of cases showed a structural incomplete response, and most of cases, 71.2%, persisted to be biochemical incomplete response or indeterminate. Among the 26 patients who developed structural incomplete response after the second radiodyne treatment, only 10 patients showed radiodyne-avid metastatic lesion. In the remaining 16 patients, the metastatic lesions were detected by other imaging procedures, and in above all them, 15 of them were detected by neck ultrasound, and they were lymph node metastases. So only 10 patients out of 153, only 6.5% of all patients had radiodyne-avid metastasis. And comparing the features of tumor or biochemical and biochemical markers, patients who developed structural incomplete response had more frequently aggressive variant and vascular invasion, and tumor were larger and tumoral marker were higher. The study group was followed for a median time of 7.6 years after the second radiodyne treatment, and during the follow-up, 71 patients received other radiodyne treatment or a combination of radiodyne and other types of treatment, such as neck surgeries or radiotherapy. At the last evaluation, excellent response was present in 26.2% of cases, structural incomplete response in 16.3% of cases, but more than half of cases showed biochemical incomplete or indeterminate response. If we divided the study group according to receiving or not additional treatment, the 71 patients who received other treatments showed a higher rate of structural incomplete response despite the additional treatment. And if we if we divided the study cohort according to the initial response in a group of indeterminate response and biochemical incomplete response, as expected, the first group had a higher rate of excellent response, as far as biochemical group has a higher rate of structural incomplete response. So, to summarize, the rate of excellent response after the second radiodyne treatment was about 12% in short-term follow-up and increased to about 30% in a long-term follow-up. In most of cases, the second radiodyne treatment does not modify the clinical status, although it allowed to identify a small subgroup of patients with radioactive metastasis. And some pathological biochemical features allow to better identify cases with a high probability of structural incomplete response. In conclusion, the second radiodyne treatment in patients with biochemical incomplete response or indeterminate response after the initial therapy should neither totally a priori avoided nor unconditional performed in all cases. Only a minority of cases who underwent to the second radiodyne treatment showed radioiodine uptake in the metastatic lesion. Therefore, it's desirable to identify this little subgroup and according to their prognostic factors such as tumor size, aggressive histology, vascular invasion, or according to the values of a tumoral marker. And in all cases not receiving the empiric radiodyne treatment, this case should be monitoring during the follow-up, and if structural disease is detected, a radiodyne treatment should be performed to demonstrate or not the radiodyne refractory status. And thank you for your attention.
Carla, I wanna Thank you so much for your work, your group's work. I want to congratulate you on this effort. And I also want to give you a big thank you for the historical recap you gave us from how we started using radioactive iodine and bringing it up to speed to what we do right now, even to the latest 2025 ATA guidelines. Thank you for that. We're going to jump with Dr. Coura-Filho to do a little bit of discussion, and we'll come back to discuss the paper and the concept of second use of radioactive iodine at the end. If there's anybody in the audience that has any questions, please send them through the Q&A so we can get to them at the end. Dr. Coura-Filho.
Thank you, Camilo, and thank you for your great presentation, Carla. It was extremely helpful to better understand the manuscript and the whole idea of your research group. And I point out that this is a very interesting subject to investigate, because we are working with two distinguished ideas that are very important in the management of thyroid cancer. One is how much treatment we shall give to the patient. And the other one is biochemical incomplete response or indeterminate responses. How frequent will they really turn into a disease that needs extra treatment? And your research was very keen into pursuing these answers, and it was very elegantly designed. In my conception, I think we shall remember always that although the radioiodine is a first-line treatment, it can have some adverse effects, and we have to select the patients who will benefit or not from the treatment. Even though many patients will need the first treatment, we have to be very careful to expose patients to a second treatment if there is not a very clear purpose on these treatments. Another caution that we always have to have is that we are treating patients and diseases, and we are not treating lab results. So sometimes we may be uncomfortable with biochemical incomplete response, but as you stated in your manuscript, only 20% of those in the follow-up will turn into structural incomplete disease. So the vast majority of the patients will stay only with a biochemical incomplete response, and even some can spontaneously become an excellent response patient. When I looked at the patients and methods, I think you were very clever to exclude the patients with structural incomplete response, because they would be polluting your sample and could lead us to or mislead us to conclusions that were not pertinent to the subject you were studying. So I think you were perfect in that sense, and thus your population became, I think, one of the most interesting populations to study. I saw also in your paper that many patients had the first treatment with Iodine with lower activities from around 30 millicuries. And one thing that I have been questioning and trying to implement in my practice is that sometimes when you have a post-operative patient with thyroglobulin 5, and you have another patient with a post-operative thyroglobulin of 1.5, I think they are not the same in quantity of thyroid remnant tissue. So maybe in these scenarios, we have to adapt how much iodine we are giving in the first treatment. Because when I was applying a more widespread activity of 30 millicuries for all patients, I saw that much more frequently I had incomplete biochemical responses when I use it in the past years to administer 100 millicuries for every patient. So I think when we go for the first treatment, we will have some patients that will need 30 millicuries, some will need something like 50 millicuries, another may need 100 millicurie. And I think in the future we'll be tailoring more which activity we'll be giving to each patient. And that's a point I wanted to highlight in your study. Also, the concept that we have to have zero thyroid globulin after a radioiodine treatment as a courted land philosophy, I think in the future will also change, and we may have some patients that will have a more tolerable range of post-radioiodine.
I think we lost George there for a second. We'll give him just 1 second to see if he comes back. But in case he doesn't, Carla, can you hear me?
Yes.
Beautiful. So while we wait for Dr. Coura-Filho to come back, I'm gonna ask you a question that came in from the audience. Dr. Jose Dominguez is asking us how you're using the data from your study in the clinical practice. Meaning, are you using the thyroglobulin concentration to make a decision of who should get or not second radioactive iodine treatment in your clinical setting?
Oh, yes. We use, for example, in patients with high risk and thyroglobulin 2.5, if patient had already treated with the radiodine, we can, before, try to find structural disease, for example, for other imaging procedures. And if structural disease is present, radiodine treatment can be useful to define the radiodine status, if the disease is refractory or not. But it's very, if we perform the radiodine to define the presence or not of structural disease, is more probably that the treatment is failure. So we with this in this setting of patients.
Correct. Thank you. This is a really good answer. I wish that Dr. Coura-Filho will come back, and I'm sure he will. I want to ask something, and I'm gonna ask Dr. Shaha. I don't know if I can take advantage of your presence and your experience here. I want to ask you from a surgical standpoint, from a surgical perspective. I've heard you give that speech where you say that a good surgeon has to learn where not to do surgery. And if we could translate that to radioactive iodine, I think as physicians, as clinicians, we have to know when not to treat patients. So when you see a thyroglobulin that is in that biochemical incomplete range, what do you do? What does that mean for you? Do you do more imaging studies? Do you? I understand that your center is not one to liberally use radioactive iodine, but tell us, what does this mean from a surgical standpoint?
Camilo, that's a great question. Before I comment on that question, I just want to congratulate Carla and George. Both of them spoke so well. And I know the University of Pisa from Aldo Pinchera, Rosella, and I think these are some of the giants in endocrinology in Italy. So congratulations for the best presentation. Now, coming to the question, I think, the management of thyroid cancer has evolved over a period of time. At one time when Mazafiri was active and aggressive, total thyroidectomy and radioactive iodine was like ingrained in the minds of every physician, every surgeon, every endocrinologist, and I would add every primary care physician and the patient. So the minute there is a small cancer or whatever, they want total thyroidectomy and radioactive iodine. Everybody felt radioactive iodine was a magic bullet, which is going to cure every patient with thyroid cancer. Over a period of time, I think we learned quite a bit about this disease. That it's not just the thyroglobulin, is it their structural disease? And quite often, I must say, when you do the first operation, you know exactly what is going to happen to this patient. Let me give you an analogy. If somebody has 10 positive nodes, deep in your heart, you know there is an 11th node that I missed somewhere, which will keep producing thyroglobulin, and there may be some trending of thyroglobulin in increase from 1 to 2.5 to 5. Does it mean that I'm going to cure that patient with radioactive iodine? I don't think we have an answer to that. Can we monitor the patient and see if there is a structural disease? Yes. What is the risk that this patient will develop structurally apparent disease? About 20-30%. Will that come to surgery all the time? In the past, we thought everybody should come to the surgery. But we realize over a period of time, anything below 1 centimeter is very difficult to find, very difficult to identify and cure the patient. So we kind of use 1 centimeter as a cutoff unless it is in the paratracheal area near the recurrent laryngeal nerve. And we just continue to monitor, and Tuttle, myself, and E.L. Rubenstock, we wrote a paper on this, about 146 patients followed for more than 4 years, with the stability of the structural disease in about 80% of the patients. So we do need to realize that the biology of thyroid cancer is much different than squamous cell carcinoma or pancreatic cancer, and these patients could be monitored. Unfortunately, we're not going to get a randomized prospective study or even non-randomized followed for 30, 40 years. It's not going to happen. And the results of thyroid cancer are not in 1-2 years. It is in 10, 20, 30 years. So I don't think we have right answers, but more and more we are distancing ourselves from radioactive iodine. And you will see that in the 2015 guidelines and 2025 guidelines. We also realize that there is a higher risk of complications related to sialadenitis, second primary. And the last thing I want to add, with the understanding of the biology of the disease and our interaction with the endocrinologists and nuclear physicians, we are now selecting out the patients who would do much better with lobectomy alone and no RAI, or in the beginning think that this patient is going to need radioactive iodine and do a total thyroidectomy. I think there is a paradigm shift in the management of thyroid cancer. Camilo, back to you. Sorry, it was a little long, but I thought it was important to discuss.
No. It's always a pleasure to hear what you have to say, and I think you nailed it. I want to ask in lieu of what you were saying. You were saying that things below 1 centimeter become really hard to catch structurally, at least. And I want to come back to George, because this is a really good question. When we see biochemical incomplete or indeterminate response, at least biochemically, I mean, what does that mean? Teach us, because sometimes when we write papers and we publish, like Carla gave us this beautiful paper, we're looking for experts in the field to read it. But I know there are some trainees in the audience, and I want you to tell me, what does it mean when you do a radioactive scan and it doesn't show up? Or what does it mean when we have a high thyroglobulin, but we don't have something to go with that, not at least structurally? George, what do you think about that? Teach us where does the radioactive iodine scan might fail and not show us something, or where we might not be able to see something structurally, but we can see something in the thyroglobulin.
Yeah, I think an important concept around a whole body scan, and especially with diagnostic whole body scans, is although it is an extremely specific examination, it has a very, very low sensitivity. So we are very likely not to see disease, especially smaller disease, such as small lymph nodes. We know that we can see frequently small nodules, even sometimes we can see radioiodine uptake in the lungs without seeing the nodules. But when we look at the most common site for metastatic diseases that are neck lymph nodes, that doesn't happen. The smaller the lymph node, the less likely to be seen in a whole body scan. So I think what we need to become more comfortable was something that Dr. Shaha was mentioning. We have to become more comfortable to just observe and follow through time those smaller lymph nodes that may be left behind a surgery. And many of these lymph nodes will not develop into clinical significant disease.
Correct. I think this is really the key point to share with the audience. And Carla, I want to come back to you. When you showed the results of your study, we saw that there's people that have biochemical incomplete response, and then they will transition into an excellent response. But if we look at those people that do not have an excellent response, that actually develop a structural response to therapy, that group is very consistent throughout time. It does not change much. There's a couple of them that transition into intermediate or to excellent, but the number is pretty much the same throughout those years that you followed the patients. So in your study, you showed us what features or characteristics we can see or identify of those patients that might not be good candidates. You mentioned size, you mentioned vascular invasion, you mentioned the histology. Tell us a little bit more. Do you think that what you saw in the follow-up is something that changed because of the treatment that we gave him, or is something that biologically is set within the tumor that gives that tumor that behavior throughout time? Is it something that we should be looking? Are we looking for multifocality? Are we looking for vascular invasion to better select those patients that we should treat with radioactive iodine in a second treatment? I mean,
Thank you. The features that you mentioned, unfortunately, tumor size, vascular invasion, were more frequent in structural response, but unfortunately not there was not difference in patient with avid and not avid. So unfortunately, we can attentionate some patient for structural disease, for more rate, for more frequency or probability of structural disease, but the definition of radiorefractory or not is on the basis of our result is not possible. And as regard patient with excellent response increase from short follow-up and to last follow-up, but more patient were patient with an initial indeterminate response in which the repetition, the second radiotherapy treatment, is useful to decrease the thyroglobulin values. So there's is an effect of the second radiotherapy treatment on the thyroglobulin values. And I want to make a comment about the diagnostic whole body scan and its low sensitivity. And from several years, we don't use diagnostic whole body scan for its low sensitivity, and we assess only the post-therapeutic whole body scan. And as regard thyroglobulin, probably and not only this single value is important, it is important to consider also the trend of thyroglobulin over time.
I totally agree with you. I think that those features, including thyroglobulin, should not be taken in a vacuum. They should be taken in the context of the patient, and of course, in the trend over time is very, very important to watch. I wanted to ask you, George, you have a comment. Go ahead.
Yeah, I just wanted to make a comment on the diagnostic whole body scan because I published a paper around 2 years ago, or three, maybe three, investigating the role of a whole diagnostic whole body scan prior to the therapeutic radioiodine. And we found out in our population that it was useful, but it was useful exactly to subtract patients from receiving radioiodine. It was useful to tell this and this and this patient, they do not have any benefit or won't have benefit from radioiodine. So, and it was focused mainly on the on patients with intermediate probability of recurrence. So I think in this population that we may have doubts either the first iodine will be useful or not. I think whole body diagnostic whole body scan can be useful to prevent exposure to an unnecessary treatment for some of these patients.
George, when you say diagnostic whole bodies, can you mean iodine 123?
Yeah, we do iodine 133, 131 with a small 3 millicuries activity.
Okay, so I'm going to speak to the rest of the world that does not have 123 available. What would you do in that scenario? Mexico, for example, we don't have 123.
Okay, you can also perform with iodine 131. The thing is, you will have less frequently seen metastatic disease, or sometimes we will not be able to differentiate if this is some thyroid remnant or it may be a lymph node in the central compartment, something that can be more easily done with iodine 123. But I think when you perform a diagnostic whole body scan with even iodine 131, and you have stimulated TG less than 5, and you have a negative scan, that patient is likely to have no benefit at all from following through a radioiodine treatment. And radioiodine treatment, especially the second or third, it's not an urgent treatment. You can always wait to make the most conscious decision.
Like some people we know, we've heard in this forum say sometimes with thyroglobulin, it's not something that threatens the patient, and we have to, and I quote, let the weeds in the gardens grow to be sure that we're treating the patient and we're giving them a benefit before we give them a side effect or a secondary effect from the treatment. Carla, I wanted to ask you, your center is a big center for thyroid cancer treatment and evaluation. I know that this population, particularly the one that you presented here, might have been treated before the coming of the molecular diagnosis, molecular tests and such. Do you have any information, or are you guys studying how molecular diagnosis plays a role in the treatment decision of giving them a secondary iodine treatment or not?
No, we don't consider molecular analysis to decision if perform a radioiodine treatment or not only for the secondary, also for the first radioiodine treatment is not assessed to perform the decision. We consider the histology for the first radioiodine treatment, the class of risk of recurrence at first. And in patients with intermediate risk, we can assess a clinical evaluation and consider thyroglobulin and tumoral markers for the first radioiodine treatment. And also for the second, the molecular analysis is not assessed.
Okay, this is really interesting. I think the field is moving forward, and I think one of the things that is moving or has changed just recently is the reclassification of the risk of recurrence in the ATA 2025 guidelines. And I wonder how this will change, or how the results of studies such like as yours will change with the intermediate have been split in intermediate low and intermediate high. I don't think anybody has the answer to that right now, but it would be really interesting to see if those features that were highlighted to split this category into two, and the features that you found, like the tumor size and the vascular invasion and such, will help us move the needle forward and better choose which patients will need a secondary treatment with radioactive iodine down the line in the future. I don't know if you have any of you have any closing remarks or comments that you would want to make before we wrap this up.
No, I just would like to say sorry for the technical issue I had early on. And I think it was a great article to read and to discuss. And I would like to congratulate Carla on the research. Very, very interesting.
Thank you. Thank you.
Yes, I want to echo that. And I want to invite all of the audience before we go to tune in back next week. We'll have a tumor board. Dr. Mike Tuttle will be presenting, and we'll have the pleasure of having Dr. Andy Bauer from CHOP present some pediatric thyroid cancer cases. I will also want to invite you all to tune in to our podcast. You can scan the code and listen to the podcast in any of your favorite podcast platforms. Voices of Wisdom is a podcast that we have put together. Dr. Dana Hartle from Gustavo Rossi is hosting these podcasts and has thought leaders internationally well known in the thyroid cancer space that share clinical pearls in thyroid cancer, and it's honestly a gem. It's beautiful, but beautifully done. I want to congratulate Dr. Hartle and the entire TIRO team for putting this together. I want to thank you all. Thank you for spending a part of your Friday with us. And Carla, George, Dr. Shaha, thank you for your insights, and thank you for being here.